experiment.
Everybody, welcome here to the VOP course. I'll be the first presenter this afternoon. My name is Laura Winfeer, and it's a great pleasure as this will be my first official talk as being a faculty member here at UCSF. And I think we have today a very interesting program around prognostic markers and new markers for diagnosis of breast cancer that is of help to identify patients what actually is the best treatment regimen they should receive. And we'll have 3 talks that will focus either on molecular diagnostics, on image analysis, on clinical implementation, and that will followed by a discussion piece by Joan Vincenki. Thank you very much for doing that, to give it from the patient perspective, which I think is always also an integral part of our VOP program, so that we actually have the full context of what we should focusing on patient diagnostics and what we can learn how to improve for the future. So I think we'll have each 20 minutes. Or kind of discussions in between, or at the end, whatever you like. Feel free to ask questions, and we'll have a more general discussion at the end. And we'll hope to have this talk end by 6 p.m. So molecular diagnostics, clinical utility of new knowledge. I'll walk you through what we all did to identify a new prognostic marker now called MammaPrint, how we went from the research part and then subsequently put this into a diagnostic test that can be used for a broader patient population through a company that I co-founded. It was founded in the Netherlands and now also exists in California, which is called Agendia. So the research part I'll talk about was all developed within the Netherlands Cancer Institute, where I used to work until last week. And the diagnostic part is something that's been taken up by Agendia. And so when we look at breast cancer, we always, the starting point of it, if we look at the histology of the disease, if the pathologist does so, this is one of an image that you could see. And actually when we are studying breast cancer, it can be done in many ways. We actually look at gene activity patterns that give an integral picture of both tumor cells as well as normal surrounding cells that you can see here within the circle where both tumor cells and normal cells are located. And you can appreciate that it's a mixture of those, and an interaction between those that actually will determine what is the shape of the tumor, but also what is the nature of the tumor and what is the aggressiveness of the tumor. So I think the stromal cells surrounding the tumor are as important as the tumor cells themselves, and other research has shown that the interaction between the two actually affects the activity of genes in either part that is present. So breast cancer treatment options after surgery and local radiotherapy are to use systemic treatment, which can be given after surgery or sometimes even before surgery. So then it's either adjuvant or neoadjuvant systemic therapy, which includes chemotherapy, endocrine therapy, and targeted therapy. And so after surgery and radiotherapy that's what happens first, local radiotherapy. Then the question is, who needs actually further systemic treatment, and are there many patients that could be cured by local therapy only, but some may need systemic therapy. And then secondly, what is the best use to use? And I will discuss what can be a way how to identify patients who need systemic treatment, and the how to treat question will more get back in the talk of Laura Espenhout, which will be the third talk. So if we take, for instance, 100 women with breast cancer diagnosed stage 1 or 2, so that's local disease, and some of these women may have lymph node involvement, local lymph node involvement, then we know that without any systemic treatment, but of course with surgery and local radiotherapy, approximately 25% will develop a recurrence within 10 years. Yet in most guidelines, 75% of all these patients are currently recommended to be treated with chemotherapy. So if you saw the previous slide, you can understand that overall some 50% of patients may receive toxic chemotherapy, of which they do not benefit because they actually don't need it, as their risk to develop a recurrence is very, very low, but they may suffer toxic side effects. So this is like a general overview of such 100 patients. And so what we asked ourselves some 10 years ago almost is, can we do better? So can we identify those patients that are indeed at high risk to develop a recurrence? So I originate from the Netherlands Cancer Institute, and there our hospital part is named after Antoni van Leeuwenhoek, who was the inventor of the microscope in the 17th century. And of course still the first diagnostic part of the to set the diagnosis is the pathologist that looks through the microscope to identify what is actually the irregularity that is being observed, for instance, by imaging. What does it actually look like, and is it really cancer? And of course a number of other histopathological characteristics are examined. But besides looking through the microscope, also cancer research in the last 30 years has given us insight in how within a cell all the networks communicate and which signals that relate to each other are actually deregulated in cancer cells, and that maybe these are deregulated in different ways, and therefore you can have different types of breast cancer. And so now the question is, are we able to identify those differences in deregulated networks? And so for instance, this, I've shown this before, this is the London Underground map. And what one can envision here is that this is the London Underground, and if you would put all the trains running on a rush hour, you would have a very busy pattern of trains and people coming in and out, as opposed to a Sunday morning where there is hardly any traffic. So are we now able to understand whether we're looking at a rush hour cell or maybe at a Sunday morning leisurely cell? And that's what we would like to know, because it can help us to understand what type of cancer we are looking at. So besides that, looking through the microscope, one of the techniques we've been exploring is to look at a microarray, and this particular technology allows us to look at the, in our case, gene activity, gene expression of all genes present in a cell, in this case a tumor cell. One can look at gene activity, then you look at expression. One could also look at the constituency of the DNA, then you would look at comparative genomic hybridization. But my talk will be about the activity of genes comparing aggressive tumors with much less aggressive tumors. So these two tumor cells here, represented by the activity of one gene, look very much alike. But here you can see that the context of that active gene, the one yellow spot, is actually in a very different context. And that is what, if you can use microarray gene expression together with bioinformatics pattern recognition, where you can sort out all the different gene activities and put them in such a way that it makes sense, that it shows you the picture of the tumor, you're able to recognize what you're actually looking at. And you can see here that these two Andy Warhol pictures are very much different. So if we look for tumors that either in patients that have a high risk or low risk to develop a later recurrence, there are several of gene sets that have been identified, listed here in the bottom, that are able to foretell risk of recurrence in patients with breast cancer. And I will allude on some of them during my talk, and I'll show you how that can be used in clinical practice. So such a DNA microarray, which in our case is actually a small glass slide, which has little spots on it, and every spot has a representative piece of a gene. And if you isolate active genes from a tissue, in this case tumors, and you put a fluorescent signal, fluorescent dye on your active genes, then you